Welcome. This is Dr. Brian Buchanan from the Department of Critical Care Medicine at the University of Alberta. I'm a intensive care doctor and clinician educator in point-of-care ultrasound, and this talk is on point-of-care ultrasound of the kidneys and bladder. Dr. Sam Shaw, internal medicine resident at the University of Alberta, has also provided some support for this talk. At the end of the session, my hope is that you'll have a better understanding of how ultrasound is used to describe the bladder and to do a basic qualitative assessment, to characterize the kidneys in both health but also in states of obstruction, with hydronephrosis and hydroureter to a more limited extent, and accurately describe limitations, false positives, and false negatives. We're going to cover the basic appearance of the kidneys and bladder in obstructive renal disease, and look at really just gross qualitative appearances to help guide our decision making. Our goal is not to supplant comprehensive diagnostic imaging, but really to supplement it and to help guide or direct or expedite that kind of imaging, especially when that kind of imaging can be delayed or lead to significant decision making with respect to renal replacement therapy or further supports. In ultrasound, you'll often hear different probe types described. We're going to focus on the curvilinear probe, seen here. This has a broad footprint, which has a longer wavelength, which allows deep penetration into the intra-abdominal structures. It provides a little less resolution than the other probes, but it's just enough for us to see the key structures. Let's talk about normal appearance of the kidneys. You need to be fairly comfortable with the anatomy of the kidney. This can actually be seen pretty well in some patients, and even in grayscale imaging. Beginning with the layers from the cortex to the medulla. Within the medulla, we see the renal pyramids, which can drain through the papillae into the minor calyces, then into major calyces, and then to renal pelvis and to the ureter. The pyramids here appear striped. This is by straight and parallel segments of loops of Henle and collecting ducts from the nephrons. This may not be seen as well in ultrasound. And depending on patient characteristics, these structures can be seen with varying degrees of success. You can see the renal pyramids in many patients fairly easily, but it can be difficult to see the minor calyces compared to, say, the renal pelvis. You'll often see the renal sinus here with all the adipose. This is where all the nerves, arteries, and structures pass through into the kidney. There's often a lot of peri and pararenal fat surrounding the kidney, again, to a varying extent. Of course, the exam is often done bilaterally if a patient, of course, has both kidneys. And ideally, you want to minimize the distance between the skin itself and the kidney, but also the overall depth. That way, we can see the kidney and adequately characterize its structures. Let's look at the bladder. Here we have the probe placed in the transverse position just above the pubic symphysis. And then the probe is compressed to allow us to see the normal anatomy. This is best done with a full bladder, but we don't always have that luxury. And of course, the anatomy can be quite different from side to side. However, the bladder is generally the first structure you're going to see here, permitting the bladder actually has urine in it. Otherwise, you actually might see ascites, which we'll come to some more later on this talk. So of course, the anatomy does in fact look different. This is simple graphical examples of imaging bladders in the transverse plane. But of course, this presumes that the bladder does have some urine in it. And here, of course, we're just showing where free fluid places itself in the relevant male and female structures. That is behind the bladder, in front of the rectum in the male pelvis, and the female pelvis most likely in the what's called the pouch of Douglas, the rectouterine pouch. Here's just an example of a bladder with free fluid in the male pelvis. This is obviously above the prostate, and this is showing a bowel, which is again immersed in free fluid. This is a normal, healthy patient scene, which we can see the bladder, we can see the uterus, and then the rectum behind that. But this is just a normal pelvis with no obvious free fluid, compared to this, which shows some more obvious free fluid with the rectum seen here, posteriorly, the uterus in the middle, and the bladder anteriorly. Again, this is with free fluid, so without free fluid, these structures aren't necessarily seen as clearly as they are here. So using the bladder, we image the bladder in the transverse midline plane, as we can see here, with the probe above the pubic symphysis and some fanning of the probe, or angling, whichever terminology you choose to accept. Usually the bladder has a more trapezoid appearance. And this sagittal sweep can provide us with some useful information for calculating bladder volumes, of course. So we can look at the bladder in transverse and sagittal planes to give us a basic calculation of the amount of mils of urine in the bladder. This, of course, is what your automatic bladder scanner would do as a basic gross and qualitative assessment. Let's go on to the juicy part here, hydronephrosis. Hydronephrosis is a pretty straightforward skill. In most patients, requires a curvilinear probe with some solid acquisition tips. We're going to focus on the anatomy here of kidneys looking for gross irregularities. It's also important to fan through the kidneys to ensure complete acquisition. We generally scan kidneys in conventional coronal plane, but also usually in the transverse plane, that's along the short axis of the kidney as well, to make sure we have a solid amount of acquisition. If not done well, you may in fact incorrectly identify a cyst and think that you are in fact detecting hydronephrosis. But on more closer inspection, you will likely be able to discern that it's not collected to the renal pelvis. This great graphic from POCUS 101 just shows how this obstruction results in some of the morphological changes from more proximal to distal, leading to pelviectasis, calyectasis. That's really just distension of the calyces, going from the major calyces to the minor calyces, and then eventually cortical thinning. And this is a really nice graphic which helps to really understand logically how the changes come about in the setting of obstruction. The classic scale shown here, the Onan scale, helps to break down some of the visual characteristics of grading hydronephrosis from grade 1, 2, 3, and 4. However, often you'll see hydronephrosis graded more from mild, moderate to severe, just because of some of the changes are just perhaps not as clear at times. This is a more user-friendly version, which shows how these changes manifest from the renal pelvis to the major calyces to the minor calyces to eventually we see this kind of bear claw appearance of severe hydronephrosis and some more of that cortical thinning. Again, I want to stress that while this Onan scale is used, especially in research settings, generally we see more kind of mild, moderate, severe, given again some of these changes are a little more subtle. Here we see various images of mild hydronephrosis. We can see enlargement or dilatation of the anechoic renal pelvis, and it's much more noticeable than you would see normally. So we see dilatation of the pelvis without dilatation of the calyces. That's an important feature of mild hydronephrosis. And really the renal cortex or the parenchyma should be fairly preserved with no evidence of atrophy. Just some more examples here of mild hydronephrosis. Again, we see enlargement, but really there's solid corticomedullary differentiation. The cortex and medulla look preserved, but certainly there is some dilatation of the renal pelvis. Moving on to moderate hydronephrosis, we see more dilatation, more black space, frankly, of the anechoic space within the pelvis and within the major calyces. And the medulla now is kind of more short and thin. This really contains both grade 2 and 3, again on this Onan scale. And in grade 2, we see dilatation of the pelvis and major calyces with normal cortical thinning. In grade 3, we see dilatation of the renal pelvis and major and minor calyces, as you can see here. And you may in fact see cortical thinning, but the cortex and the medulla are easily differentiated. So here's just more images that show these characteristics, for example. Again, we can see that there's preserved corticomedullary differentiation. But again, you can see some cortical thinning in this stage. Here's an example of a patient we recently had in our ICU, which unbeknownst to us, as we were doing some educating at the bedside, there actually was the presence of bilateral moderate hydronephrosis. So we can see that there's dilatation here of the renal pelvis, of the major and minor calyces, but we still see the cortex, we still see the medulla, but there are clear, obvious morphological changes. In the bottom left here, we can see the bladder. In fact, we can see the Foley balloon, which we probably shouldn't see because that bladder should be collapsed around the Foley balloon. And notably, this patient did not have ascites, which is always a potential confounder. So in fact, we found on comprehensive imaging this patient that she had bilateral renal stones, but also, as we detected here, some bladder outlet obstruction. And notably, this patient was producing urine. So this was obviously a partial obstruction with some chronicity. Going on to severe hydronephrosis, this is by far the easiest to recognize here because we see this, what's often called the kind of bear claw appearance, where there's really no discernible boundaries between the minor and major calyces. And usually in this case, we see very little corticomedullary differentiation here. We see frank calyceal and pelvic dilatation, really thin cortex. Some will call this calyceal ballooning, where it really loses its structure. So again, more images seen here. And obviously this is continuous with the renal pelvis. Another example here on an older machine where, again, we see really that loss of that architecture of the renal parenchyma. So this is often called grade 4, where we see significant dilatation of the renal pelvis, cortical thinning, really pretty solid renal atrophy, and really loss of that border between what we consider to be the renal pelvis and the calyces. I would say be aware of severe polycystic disease, and this can really be a fake out. And really, you should pay attention to whether those anechoic spaces communicate with the renal pelvis. If you see discrepant areas of what looks like preserved anatomy, this might be one telltale sign that, in fact, you're looking at severe cystic disease. So always check, that's certainly a case where if you're wondering, that's certainly a compelling reason to get more comprehensive imaging, or just cross-reference if perhaps CT imaging or ultrasound imaging has been performed before, or there's documentation of polycystic kidney disease. This can be an easy fake out for hydronephrosis to the untrained eye. Now looking at bladder ultrasound. Again, this is a really important part of performing this exam, looking at the kidneys. This patient here, interesting enough, actually had renal failure in our ICU and was oliguric. And lo and behold, upon scanning for ascites, we discovered, in fact, the bladder was severely distended above this level here. In fact, the bladder was partially obstructed here, so some urine was draining, but a lot of it was being held back. And to discover the Foley catheter, you do have to make sure you scan and you fan the probe down below the pubic symphysis, because generally the Foley balloon will be fairly low. This is the bladder in the sagittal position here, so we can see it resting on the base of the bladder. There are cases where you can mistake pelvic ascites for the bladder. In fact, in this case, this is an easy fake out. In fact, this patient does have a Foley balloon, but it's not well seen. And what you're actually seeing here is the pelvic brim full of ascites. A nice telltale sign of this problem is that if you were to fan upwards with the probe, you would see that there is clearly bowel that's within this contained space. So be aware, bladder scanners can have the same problem of detecting ascites within the pelvis. So just be aware, if they have ascites, it can make the bladder assessment a little more complicated, especially if a Foley is in, because that bladder can be collapsed and you'll mostly just see ascites. We see in the transverse position here that there is some bowel on the screen left, and this in fact is mostly just ascites. And the bladder is really not well seen because it is evacuated. To summarize, we read these with ultrasound to describe the appearance of the kidneys in both health and obstructive disease states, and looked at findings that may confound your assessment of obstructive hydronephrosis. We talked about the Onan grading system and using kind of the mild, moderate to severe scale. I just want to note here that we did not do an extensive review of false positives. So there are other possible causes here that can be considered. For example, parapelvic cysts. And also we did not cover renal stones, which can complicate renal obstruction, which may demand more urgent intervention. So for that often requires more comprehensive imaging, plus or minus CT-based stone protocols for imaging for renal stones. I would refer you to the POCUS101.com website. This is an excellent website for further reading on hydronephrosis. Well, that's it for now, folks. I hope we provided a solid review of examining the kidneys for obstructive renal disease and provided you with a good framework for assessment of severity of hydronephrosis. Thank you. Bye for now.